Started another one. Okay, so let's look at the second part of this of our lesson today. So let's look at now the pathophysiology itself. Excuse me. Okay. So what is now happening? Because of that distraction, right? Because of that distraction, at this point, let me quickly and briefly talk about the types, or rather the causes. Okay. So the causes, these causes that can lead to this, okay, we can have one primary causes and secondary causes. Okay, and secondary. So under primary, the most common, especially in children, is what is called minimal change. Minimal change disease. Okay. Then we can also have what is called focal segmental glomerulosclerosis. Okay. Yeah. So these are the most common ones, and then we can also have under secondary. We can have systemic lupus erythematosus. Okay. We can also have DM, and this is actually the most common cause. Okay. We can have DM, that is diabetic nephropathy. Right. Okay. Then we can also have we can also sorry. That is diabetes. Yes, so diabetes mellitus is going to cause nephropathy. Hence, it is called diabetic nephropathy. Okay. Then we can also have infections. We can have infections such as hepatitis B and C, malaria, okay, and HIV. Okay. Also malignancy. Okay, malignancy, yes, can cause types of malignancies that can cause that. Okay, so these are the causes. Now, what I meant by having two parts of this lesson is that at this point we're not going to go into details of these, okay, because these are topics on their own, right? So at this point, what we can just mention is that these are going to be the causes of that distraction to the nephron that is going to lead to what? To nephrotic syndrome. Is that fine? Okay. So now, let's look at now what is going to happen. Okay. What is going to happen is, let's start with the hematuria. I mean, the proteinuria. Okay. So what is going to happen with proteinuria? Like I already explained. Okay. One, because of increased spaces. Okay. Because of the increased spaces, these proteins are able to pass through, and also because of loss of the charge. Okay, these proteins will be able to be lost, isn't it? Because of those two factors. Now, when these proteins are lost in urine, okay, when these proteins are lost in urine, what is going to happen is that, let's look at this. We should understand that, especially, by the way, I'm concentrating on albumin, okay, on albumin and what? And immunoglobulins, okay, immunoglobulins. Now, let me first talk about the immunoglobulins, because that is quite straightforward. So all these proteins, the albumin and the immunoglobulins, that is the antibodies, isn't it? They are being lost, isn't it? They are being lost through urine. Okay. Now, if someone is losing antibodies, what does it mean? It means that their defense system is being compromised. Okay. Their defense system is being what? Compromised. So that's why you find that these patients with nephrotic syndrome, they are prone to what? Infections. Okay, and that's why most of the times you have to treat, or rather put these patients on prophylactic what? Antibiotics. Okay, or you have to investigate for what? For infections. Other than just infections being one of the causes, like we already mentioned, but they can also get other secondary infections because of what is happening to them. Then let's get back to the albumin. Okay. So now, when you look at albumin, if this is the this is the intravascular space. Okay. We have this albumin. Okay. Albumin maintains what is called the intravascular oncotic pressure. Okay. What is called the intravascular oncotic. Oh, okay. Right. So it maintains the what? The oncotic what? Oncotic pressure. Now, what it means when we say oncotic pressure, this is simply the pressure that holds fluids within the intravascular what? Space. Okay. Once this oncotic pressure is lost or it is reduced, then what you're going to find is that these fluids are going to start going out of the intravascular space. Okay, they're going to start going out of the intravascular space. Now, let's look at what happens then. Because this albumin has been lost, it means that the intravascular, this oncotic pressure has been what? Has been reduced. Hence, what happens? The water starts in, what? Going out. Water and other things such as sodium, the salts, okay? They are going to start going out of the intravascular what? Intravascular space into the interstitial space. Okay? Into the interstitial space. So these things start going out, right? Now, what does it mean? When water goes out of the intravascular space into the interstitial space, it means this is what is now going to lead to what? To edema. This is what will lead to what? To edema. Other than that, when we talk about edema, we're just looking at what is going to happen from the outside of the intravascular space. But what is going to happen within the intravascular space? Okay? What is going to happen within the intravascular space? Number one, okay, within the intravascular space is that number one, there's going to be reduced blood volume, isn't it? Okay, there's going to be reduced blood volume, and because of that, there's going to be reduced what? Venous return. Okay, venous return will be reduced. Now, according to Starling's law, if venous return is reduced, it means that even cardiac output is going to be what? It's going to be reduced. Okay, if cardiac output is reduced, remember, blood pressure is a product of what? Cardiac output and what? And heart rate, isn't it? Okay. So because of that, again, it means that blood pressure is going to be what? It's going to be reduced. So these people with nephrotic syndrome, they are going to have, at some point, they're going to have what? Reduced what? Blood pressure. It's like they are having some sort of hypovolemia. Okay, there's going to be some sort of what? Hypovolemia. Now, the other thing that is happening within the intravascular space is the fact that, remember, you are losing fluids from the intravascular space. So it means that the blood is becoming thicker, isn't it? Blood is becoming thick. Okay, so it means that there's going to be hypercoagulability. The other thing that leads to the hypercoagulability, I'm going to explain it, but one of them is the fact that you are losing the fluids. Yes, it's also there. Hypercoagulability state is also there, okay? But it's not something that is always there, okay? It's not something that is always there, but it's something that we have to look out for, okay? So there is hypercoagulability because of loss of what? Because of loss of fluids, okay? Then the other thing that is happening, that is going to happen is that, let me finish with this. Because of this, okay, because of reduced blood volume, okay, and reduced blood pressure, it means that this is now going to lead to, I'm writing in a bit disorganized way here. This is going to lead to, one, Let's now go back to the kidney itself, isn't it? There's going to be reduced renal perfusion. Okay, renal perfusion. So the amount of blood that is going to the kidneys, remember the kidneys are one of those essential organs in the body that must always receive blood. Okay, so we have the brain and the kidneys. Those are some of the essential organs in the body. So you find that the amount of blood that is going to the kidneys is going to be low. Okay, now remember we have what is called the juxtaglomerular apparatus, isn't it? Or the juxtaglomerular apparatus just near the nephron. Okay, now there is, by the way, because of reduced renal perfusion, there's going to be reduced GFR, that is glomerular filtration, what? Filtration rate. Okay, this is going to be reduced as well. So because of that, there's going to be release of what? Renin. Okay, there's going to be release of what? Renin. And this renin is going to activate. It will activate what? The renin angiotensin aldosterone what? System. Okay, that is a topic on its own, but briefly what is going to happen? This renin angiotensin aldosterone system, it really just works to restore the blood volume. Okay, so what is going to happen is that there's going to be signals that are going to be sent so that one, the sodium is reabsorbed, and once the sodium is reabsorbed, remember water follows what? Follows sodium, isn't it? So once the sodium is reabsorbed in the renal tubules, water is also going to follow. In other words, water is going to be what? To be reabsorbed. Okay, so this is trying to restore what? The blood pressure by bringing about what is called water and sodium retention. Okay, so this renin angiotensin aldosterone system, in this case, is just trying to bring about water and sodium what? Retention. Okay, now once these things, the water and sodium, once they go out, okay, once they go back into the bloodstream. Now I want you to get this correct. Once they go back into the bloodstream, remember already the albumin is not there, isn't it? The water and the sodium, they are supposed to be held within the intravascular space by the oncotic pressure, which is as a result of the presence of what? Albumin. Now, you take back this water and sodium into the bloodstream, but there's nothing to hold it back in there. So what you expect is going to happen to that water that has been taken back? It will flow out again, isn't it? That is what is going to happen. So because there's no albumin, even if this renin angiotensin aldosterone system is going to bring about sodium and water retention and temporarily raise the blood pressure, but because there's no albumin and the oncotic pressure is low, okay, this water and sodium, they are still going to be lost, okay, into the interstitial space. Okay, they're still going to go back into the interstitial space, and it is going to lead to further edema. You get the point? It is going to lead to more edema. Okay, and the cycle continues like that, right? And the cycle continues like that. The other thing, because of the proteinuria, the other thing that is going to, we've talked about it, we've talked about several things. Number one, we've talked about the edema, how the edema is coming about, okay? Then the other thing is that in order to compensate for the loss of this albumin, the liver now starts to hyperfunction. Okay, the liver starts to work harder to produce more albumin and lipids. Okay, so there's going to be lipid synthesis, okay, and formation of albumin and so on, so that it compensates for that loss. Okay, now we're saying that other than just the albumin, okay, the other thing that is being produced by the liver in the process is what? Are lipids. And the most prominent one is what? Cholesterol. That's why we're saying that there is also going to be dyslipidemia. Okay, and the most prominent is what? Is cholesterol. Hence, that's why we are saying that there is hypercholesterolemia. You get the point? Okay. So the liver, because of that loss of proteins, the albumin, because of that loss, the liver, okay, starts to work so hard to produce what? To produce albumin, which is again being lost. The more is being produced, the more is being lost. Again, the other thing is what? The lipids. Okay? Hence, you are having what? Hyperlipidemia. And this hyperlipidemia is also leading to the hypercoagulable state. Okay? It is also leading to the hypercoagulable state. So, how many things? The two things that I've mentioned that are leading to the hypercoagulable state. Number one, the presence of the lipids. Okay? Number two, the loss of fluids, such that blood is becoming what? Thicker. Okay. Hence, patients with nephrotic syndrome, they are also prone to, what? To this thromboembolic what? Phenomenon, such as DVT, okay, pulmonary edema, pulmonary embolism, even CVA, okay, like cerebrovascular accident, stroke, because of that. All right. So this is literally. So we've talked about it, all the three, isn't it? We've talked. All the four. We've talked about one. We've talked about the proteinuria. We've talktalked about the edema. We've talked about the hypercoagulable state. We've talked about the proteinemia, because of the loss of protein. So you are having less proteins in the blood. Then we've also talked about the dyslipidemia, prominently the hypercholesterolemia, isn't it? We've talked about those. So that is basically the pathophysiology of what? Of nephrotic syndrome. Okay, so let's look at some of the signs and symptoms. Okay, we may not mention all of them, but at least the common ones. Okay, so because of the proteins, number one, you're going to find that patients are tired, there's tiredness, okay, or fatigue, okay, tiredness. You find that there could also be dyspnea. Okay, now the dyspnea could be because of the pulmonary edema or the pleural effusion. Okay, pleural effusion, isn't it? Then we can also look at what is called xantholemia, where it's like you're able to see some fat deposits in the eyes. Okay, then you can also find leukonychia. Okay, leukonychia. All right. Then obviously you can see the edema. Okay, the edema, which can be peripheral edema, like I already mentioned, or generalized edema, and so on. Okay. So those are some of the things, and obviously signs of there could also be signs of infection. Okay, there could also be signs of infection. There could also be signs of thromboembolic phenomenon, depending on the situation, isn't it? Okay, and again, depending on the cause. Okay, let's say, for example, if it is DM, you're going to see features of DM. If it is HIV, it is hepatitis B or C. If it is SLE, you're going to see again features of those specific causes. Okay, but this basically we're talking about specifically the nephrotic syndrome itself. Okay, so those are some of the signs and symptoms of nephrotic syndrome. Let's look at the investigations. By the way, before I proceed, you can ask if you have any question. investigations quickly. So number one, you're going to do the baselines. Okay, that is the full blood count. Okay, you can do the urea and creatinine and electrolytes. Urea, creatinine, and electrolytes. Okay, you can also do. No, 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 no. Yeah. Okay, this one we can say renal function test. Okay, renal function test. Does that make sense now? Okay. Then we can also do urinalysis. Yes, U and is urea, creatinine, urea and electrolytes. That is U and is and creatinine. Okay. Then we can also do urinalysis, isn't it? Urinalysis. Okay. Now, I'm not going to say dipstick here. I'm not going to say dipstick because dipstick is on examination. Remember, okay? Urinalysis itself is on it. If we talk of urinalysis in terms of dipstick, that is under examination. It is a bedside, isn't it? It's a bedside examination. Okay, yeah. Then you can also do urine MSC, okay, urine microscopic culture sensitivity, okay. Then you can also do what is called, you can also do what? If you want, you can also do chest X-ray, okay, chest X-ray. Now, the reason why you are trying to do chest X-ray is to look out for features of pulmonary edema, features of pleural effusion, and so on, right? Then, number 6, you also want to do renal ultrasound. Okay, renal ultrasound, and then lastly, the diagnostic one is what is called renal biopsy. Okay, and we would probably go in details when we talk about the specific causes of what nephrotic syndrome. Okay, so this one is going to tell you. Okay, it's going to tell you what the cause. So under this one, we have light microscopy, we have fluorescent microscopy, and electron what microscopy. So this is what is done when you do the biopsy. Then you take it for light microscopy, fluorescent microscopy, and electron what microscopy. And each of these are going to reveal features that are consistent within each specific cause. If it is minimal change disease, if it is focal segmental glomerulosclerosis, and so on and so forth, those are going to be shown on a renal biopsy. Okay. Then sometimes you may also want to do Doppler ultrasound. Okay. Why are we doing that? Because remember we said that these patients are in a state of hypercoagulable state, isn't it? So you find that it is possible they may have TVT, and they actually tend to have renal vein thrombosis, where you find that the renal vein gets occluded. Okay, so it is also important to do what? Doppler ultrasound. Okay, so basically these are the investigations that you do. Then let's talk about briefly. We talk about management, the best principles of management. Okay. So the reason why we're looking at it in general, the general principles of management is that the management, especially the definitive management, depends on the cause. If it's diabetes, you have to make sure that you treat the diabetes. Okay. If it is SLE, you make sure you treat the SLE, and so on and so forth. Okay. So, but number one, you restrict you restrict salt intake. Okay, you restrict what? Salt intake. Okay, then you also restrict what? Protein intake. Now on this one, I'm going to put a star, and the reason is this: in our setting, okay, in our setting here, especially children, most of them are already malnourished. Okay, they may not be malnourished such that it even becomes symptomatic, no, but they do not have enough proteins already in the body. You get the point? So if you start restricting protein intake, okay, it means that you may worsen the what? The malnutrition. It may lead to kwashiorkor and so on. Okay, yeah. So, but in developed countries, this is something that is usually done. Okay, yeah, it's something that is usually done. Then you can also give drugs such as enalapril, okay, which is an angiotensin converting enzyme inhibitor, isn't it? Then you can also give drugs to lower the cholesterol, such as simvastatins, okay, such as simvastatin, okay, so that you lower the what, the cholesterol. Then you can also give some protein lowering drugs, okay. So basically, those are the other thing. I should also mention, you can also give furosemide. Okay, you also give furosemide to reduce the edema, isn't it? Because they have edema. Now, of course, depending on it may depend on the degree of the edema and so on. But usually, furosemide is quite recommended. Okay. That one you can give about, is it 80 to 120 milligrams per day. Okay, so those are the basic, or rather the general principles of management of nephrotic syndrome. We can look at the specifics if we look at the specific causes, like we already mentioned. Okay, but so far from what we have done, I think this may be enough, especially for you. This may be okay and enough to help you. So what I would encourage you is to go through the topic, try to the diuretics. This is where I mentioned the furosemide. Yeah? Okay, diuretics. Okay, yeah. Any other problem? Any other question?